All right, Nick, we're ready to go.
All right, everybody, welcome and thanks for attending. My name is Nicholas Foss. I'm the clinical director for Alcohol and Drug Dependency Services of Southeast Iowa, based out of Burlington, and wanted to provide some insight into how I believe we've achieved a relative amount of success in our gambling treatment program. Namely how we've gotten pretty good at being able to proactively identify clients that are in need of gambling treatment within our own existing treatment population and increasing admissions. I'm going to talk about just some points of consideration of people with gambling problems that clinicians need to be aware of and think about when they're approaching gambling populations, as well as practical elements such as the screeners that we use. I'll try to share some about a NIATEC project that we did to increase admissions by changing our screening protocol, and then I want to leave plenty of time for discussion and questions. So the first thing to think about is that by and large, when you're working with a problem gambling population, we have to keep in mind that individuals in our communities aren't educated about gambling problems. And so we may be screening or attempting to identify an issue that a person may not really be well educated or aware of exactly how it's affecting them. We all know that addiction disorders, a key feature of addiction disorders has to do with denial or lack of self-awareness, and how the substance use or addictive behavior may actually be impacting the person's personal life. And problem gamblers are the exact same, and you add to that the element of lack of understanding about how gambling problems can be addictive or how gambling can be addictive, complicates that element. And so there needs to be the preparedness of the program to be able to educate individuals first about what they're really asking about and what they're dealing with. Because if you survey, and I've heard this across the nation, if you survey a population of people, especially in a state like Iowa that's pretty gambling saturated already, and we're adding on sports gambling now, you ask a population of people, do you gamble? A lot of Iowans would say no. But then if you start to dig in and say, do you play the lottery? Yeah. Do you like to throw dice? Do you like to play cards sometimes? Sure. And so you get into more of the specifics, and you'll find out that a lot more people gambled than will let on. And we already know that's the case from substance use. You're going to have people coming in for evals that will minimize their use. So we have to understand that with gamblers. So if you're just doing a screener, and you're doing like the brief biosocial gambling screen, which is 3 questions based off of the diagnostic manual, and you ask those 3 questions, and you do no education about what gambling you're actually talking about, you're going to lose your potential to identify those individuals, and you're going to have a pretty low treatment population. So another consideration is the way that you approach treatment engagement. And we know classically that across the board with addiction disorders in the United States, we know that approximately 25 million individuals in the U.S. will meet criteria for a substance use disorder based on just statistical modeling. And when you look at that whole population of individuals that would theoretically meet criteria for a substance use disorder and addictive disorder, you see about 10% of that population accessing treatment. And one of the biggest reasons why people aren't accessing treatment from that larger population has to do with the lack of recognition of a problem, simply put. And so with problem gamblers, the treatment-seeking percentage is even lower. It's far less than 10%. In fact, in some studies, it's less than 1%. And so one of the large reasons why has to do with what I just talked about, the fact that we're dealing with a population that isn't even really aware of the condition that they have. If you meet with your average problem gambler, they're going to tell you that their real problem is money, not the gambling. They need a financial counselor. They need, or it's their wife, and whatever the stress. And this is a familiar problem as well with substance use. But that low treatment seeking tendency also has to do with stigma. How many people do we really know in our personal lives and in our even professional networks that actually have a gambling problem outside of treatment populations? I personally don't have anyone in my family that I know of that has a gambling problem. I don't have any friends that I know of that have gambling problems. I have people in my social circle that I know have other types of mental health or substance use problem. And your average person doesn't have a model to describe or to understand or even think about what that looks like or how to even conceive of their own behavior in terms of talking about a gambling problem. So treatment seeking has a lot to do with the lack of education, also with stigma around gambling problems. It's like, well, if you have ever met somebody with a gambling problem and you get to talking with them about how they feel about that, people with gambling problems are far more have I would say probably more extensive self-deprecating thoughts than your average person with a substance use disorder, because as one 19-year-old client said early on when I started practicing gambling counseling, early on he would say, well, at least it would make sense if I were talking about having a drug addiction. He said, but I have to talk about having a gambling problem, and I don't know how to make any sense of that to anybody. I feel like a fool. I feel like as if there's something deeply wrong with me because I have this problem. And so you just see that level of contempt toward the self because of that problem. So the treatment seeking is low. And the reason why I'm saying all of that is to tell you that when you're talking with people about gambling addiction and you're talking about people with gambling, talking to people about gambling problems and screening for gambling problems, you really kind of have to sell it. And you have to really do a good job of explaining how crucial of how big of a problem it can be, and the comorbidity that it has with substance use disorder problems, and making that parallel. So what we've worked on a lot of ads is making sure that when we're doing those screenings is that we're talking with people about the gambling as well, and making sure that they understand how concepts of cross addiction can work. So you may be gambling now at a risky level, but you're not meeting you're meeting less than 4 of the total criteria for some gambling disorder, but yet your gambling's risky, and you're trying to get clean and sober, and the risk of starting to gamble more heavily when they quit the alcohol use or the drug use. So making sure that we do a really good job of explaining that, kind of selling why it's such an important issue, because people aren't just going to get it when we mention, okay, now we're going to do a gambling screener, and this is really important for your health, and asking them 3 questions and blowing through it. If that's what you're doing, you're going to miss them. You're not going to get the population, and you're going to have a really low use of those dollars as well on your grant, because you're not going to be able to identify those folks. So the way that we started looking at increasing admissions at ads, because I felt like for a long time we weren't doing nearly the job we could be doing, especially with the volume. So at ads, I'll give you guys an example. Some of you guys are doing way more than this, much bigger agencies, but we'll see probably probably do 1,200 evaluations in a year or so, around that number. Excuse me. And you think about that, and if we even hit, so let's say that we did like the minimal, and we hit 1%, let's say 1% of that population of 1,200 out of those 1,200 evals, if we hit 1% of that treatment seeking population, we would be blowing through the grant already. We would have probably a treatment population we might not even be able to completely handle. And so, well, I guess 12 people wouldn't be that bad, but if we hit, even 10% of that, then we would have more than we could do. We have 1 counselor right now. We couldn't handle all of it. And so you think about that volume and the opportunity you have. We started looking at, well, we have all these people coming in. We have hardly anybody that's just self-referring for gambling treatment. We have tons of people that are self-referring or have to come in for substance use evaluations. So that's the point. We need to nail it. So we did a NITEC project, and we implemented the Disorder Gambling Expert Pre-Screen and Screen Questionnaire. And I think some of you are already using that. And the way I trained the counselors was that you have to do the script. the script at the beginning of that is evidence-based. So if you look at any of the larger names in the field of problem gambling counseling, Lori Rugel especially has advocated a lot for expert screening with problem gamblers. Lori Rugel has been a fierce advocate for making sure that you do that psychoeducational piece with your client, and explaining really clearly that first part. And there's a template that IDPH already has on their website, which is available to everybody in the open domain. And so we started using that through, at that time we were using WITS, and it was already built in WITS. And and so we utilized it, and we found that previously we weren't identifying hardly anybody in our substance use screens. Our referrals were coming from the gambling counselor being out in the community, networking, and just spending a lot of time doing educational presentations at different types of groups for substance use programs, or doing presentations at like juvenile detention centers and all sorts of places. And we were getting referrals here and there from that, and it was really inconsistent. And then we'd have some bets off calls, which wasn't very much. And so I noticed that we're getting hardly any referrals from our own substance use counselors who are screening massive amounts of people. So I took 2 counselors, and I would encourage any of you guys to use the same model, and I'll be glad to share the documentation I have for the project so you can just duplicate it. I took, I think, 1 or 2 counselors and had them switch from using the brief biosocial gambling screen and had them start using this screener. And the project was that the substance use counselor had to read the script as it was with no deviation, and couldn't just feel like, oh, I don't want to really do the screener, I'm running low on time. They had to do the script. And I observed them in some of those sessions where they were doing the screening to make sure that we were at fidelity of using the screening tool. And what we found was that we had an increase in each of the counselors that had previously had no referrals in the last year for gambling counseling, had in just that 1 month had 4, each of them. So we had 8. I think we got 8 referrals from that whole NIATEC process for those 2 counselors. And so after that, of course, I adopted the screener, and we used it agency wide. And now we get probably anywhere from 4 to 5 referrals from the screener, and we won't get every single one of those individuals into treatment, but we are certainly following up with them and attempting to get them into care, and some of them do get in. And so a big part of that had to do with drilling down and making sure that the counselors were utilizing that screener, and that it wasn't just getting blown through. Because I think what we were seeing at ads was that the counselors this was the easy questionnaire. Nobody's going to say yes to it, so I can just pretty much act like nobody's going to say yes to any of the questions, blow through it, and then move on. And of course, if you screen somebody like that for gambling problems, they're going to read right through that. They're going to like, this person doesn't want me to say yes. So no, I haven't lied about my gambling, and no, of course not. I haven't spent more than I should have, and such and so forth. So that's the first part of it. Was that we did. I think that was a huge part of us seeing more consistent referrals internally, because when I started at ads in 2010 as a gambling counselor, we were getting there were more bets off calls at that time. But we just have we've never had a robust referral base from the bets off hotline since even I've been working in this field. And so there really was the need to find out where these referrals going to come from, and the problem was us. The problem was internal, and we rectified that. I think we're doing a pretty good job now. The other thing that we do at ads is we dedicate one professional, one counselor to be the gambling counselor, and that's the lion's share of her duty, is that she is seeing gambling clients, and she's full. And she'll have anywhere from 15 to 20 cases at a time, and we have her doing some other substance use treatment stuff. We have her doing evals, but she doesn't have a substance use treatment caseload at this point. I think there may be a question, or.
Yeah, this is Allison from Sassy.
Hey.
Hi, I was just curious. Our biggest issue is we do this on every one of our patients, but our biggest issue is then actually getting them to agree and participate in actual anything addressing their gambling issues. So how are you converting, even if you have 10 people screen positive on this, how do you then get them to participate in gambling treatment?
Yeah, we're certainly not getting 100% of them either. I mean, like I said earlier, the treatment seeking likelihood that they actually seek treatment even after the problem has been identified is pretty low. And we will frankly have some people that'll just tell us, nope, I don't want to do that. I'm not worried about the gambling. I just came here, you know, and being cognizant and being respectful and understanding they came here for a substance use treatment, probably. So it's kind of like if you went to the doctor for your cough and cold and they started to want to talk to you about, you know, something else, like, well, let's talk about your blood sugars right now. You'd be kind of baffled. Like, I kind of came in here to, you know, deal with my cold and cough. So it's the same idea, is that a lot of times we are kind of hitting them with a curveball when we talk about the gambling. And so we do see that where people just kind of dismiss it. And you have to do a strong, like I said, that's where it has to come into doing a strong sell. You really need to understand how important this problem is. Of course, that's not going to perfectly work. The other thing that we do is we don't do group with the gambling clients, because we found that trying to push them into group or making them use that model of treatment has been a failure. And we learned early on that we will have the individual counseling be the basis for our program, and then the group counseling will be what we'll do. If we can get a group going, we will, and we do sometimes, but really rarely. Gambling clients, this is my experience, other programs may have had different experience, really are skittish about going to group. So many of them are self-identifying or self-referring or agreeing to the gambling treatment once you've identified the problem with them. And so they don't really have to be there. And so we found that they've, when we've told them, you know, we used to have, you know, a group is on Tuesdays and this kind of a thing. And clients would just say, I'm not going to go to group. I don't want other people to know about my gambling problem, even in a confidential setting. So we just didn't use, I think that was an important part too, is that we don't push the group thing. We just, we tell them it's going to be individual counseling, and it's, you know, we're going to work with you one-on-one, and you're not forced to do group. And so I think that's important as well. So what I was talking about with the structure of the position is we have a gambling counselor that is just, that's all she does, is just gambling counseling. And she's a national certified gambling counselor. It's, what is it? International certified gambling counselor. And she's also certified CADC as well. But we've completely dedicated that position, and we've always worked the program that way. We do, like I was saying, we do have her doing some other duties. We have her doing some substance use evaluations. But that's much less of the time she's spending. Either she's in our residential program, having some of the clients do brief screeners, or the DGSPS, following up with them, or she's doing some brief groups, like educational groups in our outpatient groups, or the residential group. She'll do a brief group with the clients about problem gambling to educate them and make sure people can self-identify, and we get referrals from that. Or she's seeing her gambling clients. So that is, I think that's the model we've used, and it has been pretty successful. I have a hard time believing we have more gambling problems in this area in rural, in Burlington. We have one casino in Burlington, and we don't have much other gambling other than lots and lots and lots of bingo and people playing the lottery. So I wonder if there are any other questions.
Nick, this is This is Vicki. I just had a question. We're using this screen as well,
Mm-hmm.
and it starts out just with a question about during the past 5 months, how many times have you gambled? And then it looks at if it's not a higher number, you stop. Is that how you're using it, or are you going on and asking all the questions even if you didn't know or under 5?
The substance use counselors, when they're doing the eval,
Correct.
they read the script as written, and then they only if they haven't gambled 5 or more times in the last 12 months, and they don't go on to the 9 diagnostic questions.
Okay.
Yep.
What have you found as to the most effective time frame to do the screener? Is it during the initial assessment? Is it during intake, or maybe after the patient has developed a more therapeutic relationship with their counselor for their substance use disorder, and they're maybe more open to talking to that counselor about their gambling because they've already developed that relationship? Do you do it a second time, maybe further along in their therapy, if they if they screen positive but don't really identify during the first time around?
We administer this DGSPS at the initial eval only, and we've found that people, I'm sure we're not getting 100% of the individuals that need help with this, but we'll screen anybody. So if they if they say, yeah, I've gambled 5 times in the last year, and they score a 1 out of those 9 items, then they're getting a recommendation for a further evaluation with our gambling counselor. And they're usually, if it's in Burlington, where our gambling counselor usually is, she travels to our satellite offices. We have 3 other satellite offices as well. But if it's here in Burlington, it'll be a warm handoff. So they'll if the client identifies that they have 1 or more on those 9 questions, and it's a warm handoff to Jessica. And of course the client can refuse, but it's a strong conversation of, hey, you really, this is really important. Jessica's great. She'll talk with you one-to-one, just a brief discussion about your gambling. And we'll get that screening done, that actual placement screening for the gambling treatment program done within the next week, next 7 days. And what we usually do with our gambling clients, other thing I forgot to mention, is we did an ITech project. This has been a long time ago. I don't believe that the syndrome itself is different as far as gambling disorder goes. I don't think it's terribly distinct in the brain or in its progression as an illness, but I think that the population is different. And so I think best practice across the board obviously is doing that initial eval and the admission, getting all that done in that at the same time. And that would be ideal for substance use treatment, but because of the volume, it's difficult to do that sometimes. And I know some of the programs that are on the call now probably do better than we do with that. I'm learning from some of you guys. However, with the gambling treatment program, or just probably 2 or maybe even 4 years ago, we did an ITech project about doing the placement screening and admission in the same session as a matter of course. And we were able to, what the goal was is to see the client through the 4th session as the aim, the NITEC aim. And we were able, and I can't remember the statistics on it of all the screenings that we did, but this was a time when we had a service area within the Quad Cities, so we were actually doing a lot more placement screenings at that time. And it was very successful to do it that way, to get them to doing the intake with the gambler and the screening in the same day, and explaining that to them at the point of contact. Okay, we're going to schedule this appointment. It's going to be a little bit longer appointment. We're going to get all this stuff done, all that rigmarole, red tape, paperwork, all up front, and then we're not going to have to go through that stuff again. And we found that clients weren't turned off by that. It actually made it so that we saw more clients staying with us on the longer term when we admitted them more rapidly rather than waiting for another session. Excuse me.
Hey, Nick, it's Allison again. So at Sassy, all of our counselors are cross-trained, and they do everything, and they do substance use and they can do gambling. So if they have a patient that they're meeting with and they identify gambling concerns in their sessions, they can work on both. So we might have a patient go to a substance abuse group, but individually they're processing and working on gambling specific and how it impacts their substance use. Have you run into any issues? I mean, are you having patients doing both and then having to come to 2 appointments a week? Or are you doing a gambling patient having a session at 11 o'clock and then going and seeing their substance abuse counselor the same day? Because we don't do same day stuff like that. So I'm just curious how you do it there.
Yeah, no, we have a gambling counselor. She's the one that does all of the gambling treatment. And yeah, so they'll potentially be coming in more than 1 session a week. And we haven't had anybody complain about that. In fact, we've had people say that they appreciated having more, especially if they're in our residential program. They love it. So Eric sent me a message. Oh wait, there's some comments here. I'm gonna check really quick. Colleen says we have implemented a gambling group in our Ames office, and we found that our GA clients prefer the group. There aren't really any GA support groups in the community, so they have found a lot of value being in group with others struggling with gambling. Yeah, we don't have Gamblers Anonymous in this area, and we also don't have Gammon on. I've found the opposite. We haven't had the demand for group at all, and when we've told people about group, they've been turned off about it. But that's like I said, that's a specific treatment population here. So I certainly can't generalize that to the whole world of gambling problems. So I think group is really would be best practice to have it all going on, but we've just found that it's been a turn off to people that they haven't wanted to do it, and so in an effort to not lose that population that you already feel like you're struggling to find, you opt for the individual sessions. And then Eric, can you help me understand exactly what you want me to do with this? You said you want me to talk more about disorder gambling screener, and I think I've pretty much told you guys where we're using it. We do, the only other thing is we do a follow-up with our residential clients. We do a follow-up screener with them. Just the likelihood that somebody with a severe substance use disorder has a gambling problem is so much higher. We capitalize on that. We use that captive audience, and we'll screen them again in treatment.
This is Andrea with CFR.
Yep.
Could you talk a little bit specifically about how you are billing the contract in the use of the screener as well as the referral? And I just want to make sure that we're capturing every entry of care necessary to draw the dollars down. We're certainly struggling, it sounds like, as well as other agencies, and bringing those contract dollars down. So could you just kind of do an overview from the screener to the placement screening and then admission, and make sure that we're just not missing anything for billing?
Yep. So the disorder gambling screener right now is part of the substance use evaluation. So we're not billing for that when it's part of the substance use evaluation. Although I'm hopeful that IDPH will let us all bill for that as part of the IPN.
Okay.
And then once they're identified, we're going to get them a placement screening in the next week, and we're going to bill IPN for that placement screening through the IPN. And we're going to admit them that same day, so we're also going to bill for that admission session for however long that part takes. So we can only do the 1 unit, $125 for the placement screening, and then the admission session, the $55 an hour, or $55 every 30-minute unit. And so that's how we're using that. And then if it's a residential client, we screen them as well, and we had to get an exception request from IDPH to do that, to be able to provide do that placement screening. So we'll proactively do placement screenings with the residential clients, and we'll bill the IPN for those.
And
So
are you billing that as a crisis session or as a 30-minute? What kind of contact are you billing for that?
We're billing it as a placement screening. Well, if we do, actually no, we're not. We're billing it as early early intervention, I think, is what Jessica's doing, because we're not doing the full placement screening unless they identify. Because we have found with our residential clients, because a lot of them are, I mean, you guys know exactly what it is. You know, a lot of them are coming in, and they may be, when they show up intoxicated, they might be coming, in detox. Sometimes they're not, answering the questions really well for the gambling screener. So we started following up with them. So we're actually building early intervention for that, like a crisis. And then if they identify as needing a placement screening, then we would build just the placement screening with them. We have a 20-bed facility. We usually have at any time probably 3 to 5 residential clients that are in our gambling treatment program as well.
So does that hurt any of your outcome rates? I mean, if you're doing placement screenings on those that need it in residential treatment, but then, as we know, people leave and they don't return and you don't keep contact with them, is that then impacting your outcome rates of, completing treatment once they're screened?
I haven't seen a lot of the people that get the gambling counseling. I haven't seen them leaving, but some of them have, yeah, so it hurts. It has happened, but it doesn't happen very often with the folks that get the gambling counseling. I've seen them stay for 60 days with us usually. It helps a lot when you're giving them, it's an enhancement of their treatment. So they're getting by default more care than the treatment as usual. There is the challenge with those residential clients though of, obviously they're on a schedule. And so whenever Jessica needs to meet with them, it might be like during their personal time or something. So that's kind of sometimes makes the clients feel like they're like running ragged, but I mean, it's more treatment.
Yeah. So Nick, I'm just going to jump in and maybe do some clarification and maybe help provide some guidance in the use of the because certainly, I'm preaching to the choir here. Everyone's struggling and pulling down their dollars except for a couple of programs. And part of it is, and we've seen just, almost an historic drop in the utilization of the program since January, and a lot of things, and there's a lot going on. So really trying to, appreciate the question, appreciate Nick jumping up and sharing a little bit about his experience from the ads perspective and the use of the DGSPS. But remember, from an IPN perspective, is that every patient who presents for an SUD disorder should be screened for a gambling disorder as well. Anyone who shows up for a gambling disorder should also be being screened for substance use disorder. That's required. If you're using the DGSPS as that screening tool, where the early intervention piece comes in is if they screen positive, then you can make a referral for that early intervention piece, and you can bill that as an early intervention piece. And if that leads to a placement screening, then you can bill that as a placement screening. But the fact that you're actually providing the DGSPS is not a billable item. It's what happens as a result of the DGS, which then become billable, if that helps clarify that.
Yeah, and if somebody, what we've done, thanks, Eric, and what that brings up a thought. When I said about the warm handoff, if somebody identifies the gambling problem, we haven't been able to do this like 100% of the time, but what we really try to do as much as possible, and the times when this isn't possible, obviously, is if Jessica isn't here, but she's usually in the building in our Burlington office, where we see most of our clients identify for gambling problems are in Burlington. We've always had a stronger population in this larger area. Obviously, has a casino here. We try to get them a warm handoff right over to Jessica immediately if they screen positive, and all the counselors do a really good job of advocating for that. I hear everybody saying, we're training our counselors. I think just the attitude about how the counselor goes about it is really important. And with what level of urgency do they treat that? Okay, they screen positive, say we need to have them talk with somebody about the gambling problem right now, and if I can't do it, then somebody's going to do it.
Well, Nick, and I'm just going to jump in here. Many of you have heard Michael Burke talk. If you've not had a chance to hear Michael Burke, or you've not read his book, Never Enough, I would highly recommend that you read that book. It's a quick read. But it talks very much about the interrelatedness between a substance use disorder and gambling. And one of our tenets, and I'm preaching to the choir here, and I know this, at least I hope I'm preaching to the choir, is that our job is to identify what are the things that can help, that could potentially hinder someone's recovery pathway. I mean, I put a little bit of a note in there. And what we hear over and over again from people who come in from substance use disorders, because you could expect, again, Nicholas is much better on the research on this than I am, but you could expect between a 20 and 30% positive rate on these screens in working with the patient. I think Allison can talk a little bit about how they've backdoored, and I use the phrase backdoor, from a financial perspective. When you start doing that financial assessment of a patient, then you start finding out about the gambling because they didn't identify the gambling. So when Nick talks about you following this DGSPS as the script, you have to be very, very intentional about you're actually educating the patient about what gambling is, and then just say, how many times have you done these activities in the last year? If they answer 5 or more, that's a cause to say, from a research perspective, we need to ask you a few more questions. And if they screen positive and they're saying, hey, I'm not interested in pursuing that, you just put that aside. You're going to address it on the ASAM and kind of use that as a teachable moment, as if their recovery pathway, their journey does not go according to their plan, to be able to start pulling that back out and saying, so tell me a little bit about what happened on day 3. You either went out and you drank again, but they went out and drank again because they went to the casino and they lost. And that triggered the drinking, or vice versa. So I think there is just really that it's always an ongoing evaluation when you're working with a patient. So they may initially screen negative, but as you're continue to working with that patient who may be in a substance use disorder treatment, that doesn't mean you don't come back and screen it a little bit more based on the history that you're hearing, using that example of, financial things that might be happening with them. I don't know, does that help, Nick? Kind of where, and the other thing, Nick, before I wanted to go as far as other scenarios, and correct me if I'm wrong, but I mean, the DGS you've used in settings outside of ads. You've taken that to correctional centers. You've done it out in the community, and that's really what I was wanting to maybe have you talk about, is how you've used that the DGSPS outside of just what you've done at ads.
Yeah, we take it to the Mount Pleasant prison, which is a treatment center. I think it's kind of like maybe Mitchellville. I can't remember there's another prison that's more treatment oriented, and so Mount Pleasant prison is a lot of the individuals that are there for trafficking drugs, or having, obviously as a symptom of their disease, getting locked up for that. And so whenever we would do those educational presentations, we would take a screener with us. And we would also do that at the Ottumwa Halfway House. We've done it in the Burlington Halfway House as well, and identified individuals with gambling problems there. Did a lot with the jails. The jails don't let us do this anymore, but we used to, whenever we would do presentations in Lee County and in Des Moines County, we would go in and do a presentation with the inmates there that were willing. They would just announce it over the PA at Gen Pop, or in the Supermax, wherever people were interested, wherever they had the most people at the time, and they would just let people self-identify, and we would do that presentation every week, and go in there, and we would have the individuals. We'd always have different people coming in. It was hardly ever the same people, and we would just I would have Jessica go through and administer at that time we were using the brief biosocial gambling screen. We just give that out to everybody, have it on a paper form, and let them fill it out and talk about it. And you'd identify quite a few people in there that needed help. And then she would do the placement screening in the jail, and we would even do treatment in the jail there, but they don't let us do that anymore. They've had a bunch of population problems and haven't been able to accommodate as many outside supports, which is a shame, but that was one thing that we were able to do really well. And as far as the treatment seeking, what Eric was talking about, the 20 to 30% of the individuals with substance use disorder identifying with gambling problems it is more likely. It really is, in my experience, has been all about the way that you present it to somebody. If you have, that's why I observe the counselors when they're practicing, when they're doing these screenings. I'm paying really close attention to how they're doing that gambling screener, and they know, and the counselors know I'm looking for it, and they know what my expectation is the way that it's done, so that we're actually identifying people and it's not just a blow through questionnaire. And I think the reason why I harp on that so much is not because of my lack of faith in any of our programs on this call. It's just because I know that it's with counselors, they get into that not in my backyard kind of a thing. I've had counselors here at ads that have that attitude where, it's, I don't have that many gambling, or my clients don't gamble, and those kind of attitudes. And you have to be really careful about that and make sure that you foster that community of understanding around gambling problems and do that good training. So that's a really important thing.
I have a question here for Nicholas. One of the counties we serve has a casino there, and we wanted to know what that looked like for you guys as far as network support, treatment, and prevention. You know what I'm saying, as far as having staff go to the casino or anything like that.
And my experience has been, it's been pretty it's been pretty difficult. We haven't had a lot of success working with our local casino here. We had more when we had a contract in the Quad City area. There was we had Clinton, Wild Rose,
Wild Rose, yep.
The Wild Rose, and then we had Rhythm City and one other one, Isla Capri, and they were really easy to work. They were much easier to work with than the casino we have here in Burlington. Is pretty closed. We'll get maybe once a year around Responsible Gaming Education Week, we'll get like an opportunity to go and like talk to their staff. I had proposed, one of the things I wanted to see was that we have more collaboration with their security personnel, and I was never able to get that to happen. And I just felt like I was constantly trying to talk with them and wasn't getting anywhere with it. I know other programs have had great relationships with their casinos, and I think it's just a case-by-case basis. So if you have that relationship with a casino, take advantage of it. If I had that, I would have my gambling counselor there weekly, doing work with the casino if I could. But I mean, in my mind, it would make sense to have the gambling counselor available there at strategic times. I mean, I'm sure the casino could tell when they have the most problems. And if it were an evening time, we could just schedule it with the counselor to be there during the evening on certain days of the week when they see the traffic, and have them available for the DCI or for the security personnel to refer to the counselor and have the counselor part of an early intervention or something, and do those kind of things. I had all those desires to do that kind of work and really be collaborative, but there's obviously challenges to that model, and the casino has some limitations on what they can do. But my in and the area I thought would make the most sense, and where Wes Erickey from the Iowa Gaming Association also seemed to support, was working with the security community within the gaming industry. And I haven't been able to get it done, but that doesn't mean some of you guys couldn't, and I'm sure you could with the positive relationships you have.
Thank you.
Yeah, I would capitalize on that. Training, working out a thing where the prevention team is able. And I don't know anything about prevention, so I'm probably, foot in mouth kind of thing. But I don't know anything about the IPN prevention part. I know it's changed a lot. That's all I know. And if it's possible to have prevention going in there and working with their new recruits, their new hires, or just doing frequent trainings, collaborations, weekly team meetings with their security personnel. I'm sure we could build that to the network support. I mean, I know we've probably all blown through that money, but those are things that I wish we could do, but I haven't ever been able to get done over 10 years of trying to do it with Catfish Bend.
Yeah. Nick, I'm just going to jump in too. I think that's a great question from, the whole continuum of, how do you have that relationship with the casino? And certainly that's something we're working on. I've had meetings with Wes Ericke, and one of the things I'd asked him several months ago, and he had got it, and then something happened and we don't have it. And so just put another request in him when I met with him last Friday, is to be able to provide for the IPN the security contacts at each of the casinos. So look for that to be coming hopefully in the next couple of weeks. It is all about relationships, and some of you have great relationships. I don't want to put Jackson or Prelude on the spot, but I will tell you both of them have done great jobs with doing things locally, even, and I believe Prelude, I don't know if we've got anyone on Prelude going on, that they've been able to, have a monthly table, even if the monthly table, and I believe they've even had one of their counselors been made available on the floor during those high business volume times. That makes sense, so the security folks could take and have contact with individuals who might have questions about self-exclusion or just having a bad day on the floor, etc. And so it is a bit about that relationship building, which some of that falls under the network support piece of your contract. Certainly there's guidance that's coming from Julie Hibben and Katie B regarding prevention activities that will be happening, and there'll be more coming as we look at the SFY 2020 work plan. So no, we're talking about all those things as well. Nick just sent a message to me. He had an emergency and he had to walk out. He wanted to certainly thank all of you for being on here. I really appreciate him and your guys reaching out to him. Feel free to reach out to Nick at ndfoss at ads.iowa.org. I think most of you know how to get a hold of him. With that being said, are there any other questions that I can be of assistance with? We've got a couple of minutes left, about 5 minutes here or so before I've got to move on to another appointment. Any other questions from anyone else for the good of the cause out there? I'd be more than happy to do what I can to help.
Eric, if we are going to do the SBIRT pre-screen during residential stays, if they've already had some other kind of screening like the LIBET or something, do we need to have any kind of exception request for that, or can we go ahead and just screen and bill for that?
So yeah, that's a great question. So if you have not, as a residential facility, put in an exception request to provide gambling treatment services at the residential level as an add-on to your menu of services that you're already providing, then you would need to submit that. Then yes, you would be able to bill that. Programs like you heard Nicholas talk about what they've done. I believe CFR has done it. I believe Pathways has also done it historically, is where they've provided the gambling treatment services in group and as an individual as an add-on to the residential per diem that you're getting for SUD. And again, with the understanding this is an add-on, that it's not something that's currently covered in your per diem for SUD treatment. Does that help, Melissa?
Yes, that does. Thank you.
Yep. Good. Any other questions?
Eric, this is Vicki. Just an FYI, when we had Dan at our directors meeting, we also talked with her a little bit about having these pre-screen highlighted a little bit more in the SUD evaluations and perhaps paid for in the same way that we have the PHQ-9 in the past. And I think that would help us as well to pull down the dollars and also continue to emphasize that and train our staff and to work with it more specifically. And I know she was going to come back to the team, but just to let you know that we did have that conversation.
Yeah, it is that, it's that, and I hear that, and I think we've not had that discussion internally, but yeah, it is sort of that, you're required to do it as part of your evaluative process.
Correct.
you know, and it's not necessarily an add-on, but I think like Melissa brought up the example of, well, we did the Lie Better, we did the BBGS, and now, hey, we're just doing a follow-up as part of that. One could argue, well, why aren't that just be part of the normal process? But I hear that. I mean, absolutely, we want you to pull down your dollars. And so I guess the other thing that I would encourage you to be thinking about, Vicki, would be those types of things. What are the out of the box things that we can do to identify those individuals who would benefit from the services? And a lot of that is outside the doors of your agencies. Certainly you have a captive audience for the substance use disorder folks that are coming in and presenting for services. That's a good first place to start, but it's also about how do you build those relationships with potential referral sources out in your new network, because you're a new provider. You know, the bankers, the lottery vendors, the CPAs, the senior centers, et cetera, where we know that there's going to be a better chance that, actually, better chance, we're talking about gambling where I'm talking about chance, but a higher likelihood that you might be able to identify those individuals in your community that may not even have known that resources were available to help them. Good questions. Anything else? I have time for maybe one more question. Well, thanks everyone. Again, a shout out to Nicholas for hosting and providing information. Hopefully this was helpful. I mean, certainly if you've got questions, feel free to reach out to Nick or reach out to myself as the gambling treatment lead. And we'll do my best if you've got questions, or I know many of you are at the point of, you know, you've got a bunch of treatment dollars to pull down. So do some out of the box thinking. We'd be happy to hear what you think of what we might be able to do to help you use those funds and spend those funds down by June 30th. So with that, thanks again, everyone. We will get this posted hopefully next week and get a link out to you for those if you need to share it internally or for others. So again, thanks everyone. Please have a safe and enjoyable holiday weekend. Thanks everyone.
Thanks, Eric.